Hi, this is Terry Pratt. I'm one of the faculty members for the North American Institute of Manual Therapy, and this is a palpation video using primal pictures to give you the lay of the land for some of the structures we want to look at C516. There's a lot of different structures in the neck and in the cervical spine, and we just want to make sure that the areas that we're going to cover during the lab portion of the course you can visualize better, and this program does an excellent job at getting you to that point. So one of the best ways I find of getting the lay of the land is looking at the bony landmarks first. So we're going to find the external occipital protuberance, and it's that first bump on the back of the occipital bone. From there, you have this superior nuchal line and inferior nuchal line. And you're going to have attached, close to midline, the upper traps. And you can always, when you're palpating muscles, have the patient contract a muscle in its action, just to see if you can feel that particular muscle. So you can work your way from the upper traps to the sternocleidomastoid, which is a long, broad tenomuscular insertion onto the occipital bone and coming a little bit over to the temporal bone. And I just want you to also appreciate splenius capitis, which you will be able to see, that's the front side of it, that you have to palpate through several layers of muscle eventually to get to some of the structures that we're going to be palpating. And it's important to realize that because when we're palpating, sometimes you may think that you're on a particular structure and you're not. As we progress further, what you're going to find is that you're going to need a system in order to be able to palpate these different areas. So you're going to go from the external occipital protuberance across the occipital bone onto the temporal bone, past upper trap and sternocleidomastoid. You're going to find the mastoid process. A key landmark is to find the mastoid process and the angle at the mandible. And in that soft spot is a structure that's tender, but it's the transverse process of the first cervical vertebrae. That's where we're going to have obliquus capitis superior and inferior attached, and that's going to be a reference point for when we're going to do some of our manual therapy, when you're trying to find the C1, C2 joints, or the CO, or the occipital atlantal joint as well, or the OA joint. Now that we've comfortably found those structures, we can show you a system to be able to palpate the suboccipital muscles. So what you can do is find the external occipital protuberance, and then you'll be able to go down to C2. C2 is the first bifid spinous process. You can also carry down to C3, which is a little bit harder to palpate, and it gets even a little bit harder as you get down to C6. The next big bump you're going to feel is the seventh cervical vertebrae. So once you're getting your regional anatomy, you should be able to go down and palpate along the facet joints, and you can feel over where you think the joint capsules are, and you can find C2, C3, area of common dysfunction, C3, C4, and keep working your way down and getting a sense of motion. And in level 1, that's what we want you to appreciate. When we get to the higher levels of manual therapy, you're going to have a sense of motion at some of these different levels. So get used to palpating along the articular pillars and finding the joints of these areas. So now we'll zoom in a little closer and look at the suboccipital muscles themselves. Again, finding that external occipital protuberance and coming down to C2 will be helpful. But what I like to do is come over to C1 and palpate obliquus capitis superior first. You can contract the muscle, have the patient rotate their head, in this case to the left, to kind of feel that muscle kick on a little bit. Once you get a good idea on how that muscle feels, you'll be able to palpate obliquus capitis inferior as it comes down to the C2 spinous process. Now you'll see here that we have the medial branch of the spinal rami at C2, and this is the greater occipital nerve, and it will actually go through obliquus capitis. So we can make that muscle translucent, and you can kind of see some of the neurological investment. What you can't see, and what I'll show you in class, is that obliquus capitis inferior also has myodural bridging. So that means the muscle and the dura actually have connections near the tendon. And this may be one of the reasons anatomically why somebody has a cervicogenic headache. Continuing on from C2, we can work our way from C2 back up to the occiput with rectus capitis posterior major, which comes very close to obliquus capitis superior, and then going right midline, very thick and sometimes sensitive more on one side than the other, and running very posterior anterior is rectus capitis posterior minor. So that gives you a good idea of the lay of the land of the suboccipital muscles. So the last couple items that we're going to look at, one we're going to look at is the posterior triangle. And what it is that you have the sternocleidomastoid, which is the anterior border of the posterior triangle, and the trapezius, which is the posterior border. So the anterior aspect of the trapezius is actually the posterior border of the posterior triangle. Now, why is this so important? Well, laying down here, and I'll make lying down here, and I'll make the clavicle a little bit more transparent, will be and I'm going to actually just bring this up a smidge so you'll be able to see it better, is anterior scalenes and posterior scalenes. And there you have the upper trunk of the brachial plexus going in between. And you can eventually get good at palpating some of the trunks and some of the pathways of some of the nerves as they come up into the neck, because where they come out of the foramen sometimes is very sensitive. I also want you to appreciate where the scalenes attach, which is on the first cervical rib. So when you're palpating down the facets, you're going to find a bump that's going to be the transverse process of C7. That's going to be the bigger bump. You see how it sticks out more than C6. So there's that bump on this side, and then you will be right on the first rib if you just go below that bump. So that's the next big bump, and it's in the posterior triangle. So I'll work during the lab portion of the class so that you can figure out where the first rib is in relation to the other structures, because it's very important to be able to assess this joint and also the first rib joint and this structure, because there's so many other pertinent structures that attach close to it or run close to it. There are two other anatomy lectures at C516 that are done by Bryant Miller, and they're important to give you some regional understanding of some of the pathology in the area. This video was intended to give you a three-dimensional view of some of the structures and appreciation, because it's really hard sometimes to visualize some of these structures. When we go to do ligament stress tests, there's going to be another video that you can look at as well. That way you can appreciate structures like the ligamentum flavum and the alar ligament. So at NIOMP, we're really focused on getting you comfortable with palpating and the anatomy of the area so your manual therapy techniques can be more effective. So thank you very much. So now we're going to work our way towards the front and just take a look at the hyoid bone in C3. So the hyoid bone is right about the level of C3. Now this is important for a few things. One is that you have your internal carotid artery and your carotid sinus. So if you're at the level of the hyoid bone and you're trying to palpate the carotid pulse, you do not want to be that high because you don't want to be palpating over the carotid sinus. You want to be close to where the thyroid cartilage is, and that's a safer region to palpate the pulse of the carotid artery.